I'd like to say welcome everybody to our December meeting. We've got a great speaker, Dr. Stephanie Kaiser. This should be very interesting for a number of us because a number of us are women with heart issues. And with that, I look forward, someday we will have in-person meetings again, obviously not in the near future. And with that, I'm going to turn this over to Laura.
Thanks, Susan. And also welcome to Mended Hearts of Oakland, number 188, to both our speaker and everybody who's here. This is our Zoom meeting for December. I'm Laura Kinley, your program chairman, and Bill Dean is our Zoom Meister for today. A few notes about Zoom etiquette. In an effort to get everybody's questions answered, when you have a question while Dr. Kaiser is speaking, write it in the chat. In fact, everyone look down at the bottom middle of your page and click on the chat icon, and it will open up a little thing on the right-hand side that is where all of the chats are. And if you'll see, there's already a hi to May and a hi to Lorraine. And if you'll be typing in that little box down on the very bottom. Does everyone see that? Okay, so that's where your questions go. Sherry, did you see that okay?
Yes.
Okay. When you have that question, write it in the chat box and send it out to everyone. And then we'll start with your questions in the Q&A portion, whether that's at the end of Dr. Kaiser's presentation or it breaks along the way. And also during the Q&A portion, please turn your video on so that we can see you and have your name showing. We are recording this. Our speaker this month is Dr. Stephanie Kaiser. Dr. Kaiser did her training in internal medicine, cardiology, and in interventional cardiology with Kaiser Permanente in both San Francisco and Los Angeles. She joined the cardiology department of Oakland Medical Center in 2017, and she's now also the Assistant Chief of Cardiology for the entire Kaiser East Bay. Her areas of special interest include diagnostic coronary angiograms, coronary angioplasties, and coronary stent placements. Dr. Kaiser's talk today is on cardiovascular disease in women. Did you know women's signs of a heart attack are often very different than men's? Or that the majority of studies on heart health have been on men and then applied to women? Dr. Kaiser's talk is the first time we've had a speaker discuss how women are impacted by cardiovascular disease and the differences between men and women in both symptoms and impacts. Dr. Kaiser, would you take us to full screen and speaker view? And
yes, thank you.
Start.
Thank you for this fantastic introduction, and thank you for having me today on this sunny day in the Bay Area. So let me just go to my full screen view here. And again, the topic today is cardiovascular disease in women, and I'm going to focus on coronary heart disease, ischemic heart disease in women. And we'll start with a quick introduction here. We'll go into traditional and non-traditional risk factors for developing heart disease. We'll talk a little bit about the clinical presentation, the diagnostic approach, morbidity and mortality, and we'll look at some of the challenges and what is the future. So basically, if you look at cardiovascular disease, it can be grouped into 4 big groups. So one is coronary heart disease. One is cerebrovascular disease, such as stroke or a transitory ischemic attack, where the symptoms of a stroke don't last for a longer period. Peripheral artery disease, meaning blockages in your arteries, in your arms and legs, for example, or arteries going to your head, which can lead to intermittent claudication, meaning it can cause pain in your legs while walking, or aortic atherosclerosis and thoracic or abdominal aortic aneurysms. So Having looked at this, cardiovascular disease was long thought to not be a problem in women. And it was actually thought that the #1 killer for women is breast cancer. There's still kind of this belief out there in our society. But it is really important to know that 9 out of 10 women have at least one risk factor for cardiovascular disease. And we see what those are in a little bit. Cardiovascular disease actually does account for 1 of every female death. So in 2016, cardiovascular disease caused the death of over 400,000 females, and this is more than total combined death from cancer, accidents, and diabetes in females. So quite a high and impressive number. So if you see this here, this is kind of a heat map of the US. You can see that some areas are affected more by heart disease and cardiovascular death than others. If you look in the Bay Area, actually, we're doing fairly well. So that's good news. Even though we do have heart disease here, we're not impacted as much looking at heart disease death rates compared to other parts of the country. So what about the awareness and research? So the awareness of cardiovascular disease as a primary cause of mortality in women has been slowly increasing. So looking back to 1997, only about 30% were aware that this is a leading cause of death. So really a small number. And we're still not at 100%, even though we have been improving, we haven't reached that goal yet. A problem really is that the research focus, and this is something you already mentioned in your introduction, has been on men. So decades of sex-exclusive research have reinforced the myth that coronary artery disease is a uniquely male affliction and have generated data sets in which men are the normative standard. So women are either included in really small numbers or not included at all. So the extrapolation of these male-generated findings to women has led in some cases to biased standards of care and has prevented the full consideration of several important aspects of coronary disease in women. So Bernadine Healy, who's a physician, described the so-called Yentl syndrome. And some of you may be familiar with this, with Singer's short story, which basically was made into a movie with Barbara Streisand. And in this movie, Barbara Streisand had to disguise herself as a man to attend school and study the Talmud. And the name is used to call attention to the paradox of adverse outcomes of women with coronary heart disease, ischemic heart disease, as well as the underdiagnosis and undertreatment of this particular issue in women. That only when women look like men, meaning they have the typical form of coronary heart disease where there's obstruction in the coronary arteries, they are diagnosed and treated like men. They get the standard of care. Are there any questions so far at this point? Or is it okay if I move on to risk factors?
Mm-hmm.
Nobody in the chat room.
Yeah.
Okay, very good.
Looks good.
All right, good. So why does heart disease develop? What are risk factors? So we basically look at traditional risk factors and non-traditional and emerging risk factors that we weren't really aware of. So the traditional risk factors apply to men and women, and the ones listed here, a lot of them we can actually do something about, and we can try to modify our risk. Some things like a family history, having a genetic component of predisposition to heart disease, we unfortunately can't do anything about at this point. But things like diabetes, smoking, obesity and being overweight, physical inactivity, high blood pressure or dyslipidemia, meaning issues with cholesterol, those are all risk factors we can do something about. There are risk factors that are very unique just to women. So if you deliver a child early, such as preterm delivery, that predisposes you to heart disease and is a risk factor. Hypertensive disorders of pregnancy, meaning you develop high blood pressure while you are pregnant, is a big issue. Gestational diabetes, again, developing diabetes during pregnancy is a big issue. Autoimmune diseases that also affect women more than men can predispose you to heart disease. And then breast cancer treatment is unfortunately also something that doesn't only cure breast cancer, but can predispose you to heart disease. Certain drugs that we use can weaken the heart muscle and cause heart failure. And then radiation therapy can actually lead to development of blockages in the arteries, specifically at where the arteries are taking off. And then depression is one of the risk factors, and it's also more prevalent in women. So when we look at the traditional risk factors a little more closely, such as diabetes mellitus, which is a chronic disease associated with abnormally high levels of glucose in the blood, either to inadequate insulin production or inadequate sensitivity of cells. Again, this is a risk factor for men and women, but women with diabetes have a threefold excess risk of fatal coronary artery disease compared with non-diabetic women. And then also myocardial infarction with earlier occurrence and higher mortality in diabetic women compared with diabetic men. What we have seen is also lower revascularization rates in diabetic women compared with diabetic men. So it means if a woman is diagnosed with blockages in her arteries, she may not undergo surgical intervention, which would be needed, or may also not receive stents in order to open up those blockages and treat them. Diabetic women also have a higher risk of developing heart failure compared with diabetic men. So overall, women kind of grab the short end of the stick, because even if a man has diabetes or a woman has diabetes, the risk for a woman is overall higher. Smoking is also a big factor. So basically, women who smoke have a 6-fold increase risk of myocardial infarction. There was a meta-analysis, meaning there were studies that were pooled together and they looked at those. And in all age groups, with the exception of the youngest, women had a significant increased risk for coronary artery disease conferred by cigarette smoking compared with men. It was a quarter risk higher, so 25% increased risk for women.
We've got some questions now.
Okay.
Before you get off of the smoking and go on to another one. Bill had one. What about other types of cancer, such as ovarian treatments, having an impact on heart?
So ovarian cancer in particular, I think some of the chemotherapeutic drugs may also have an effect, but I'm not 100% sure on that. The main thing is really the breast cancer treatments. There are certain drugs that really can reduce the pump function. What happens during those cycles where patients are being treated with this chemotherapeutic drug, their heart function is monitored very, very closely. In some cases, they're being placed on drugs that we used to treat heart failure already in the beginning to try to help preserve the pump function. So they're being followed very closely. And if the pump function drops, unfortunately, to a certain degree, that can actually lead to the therapy needing to be stopped.
Another question that might impact, I asked how depression affects the heart in women. Is it the pump? Is it that pump action? It slows it down? It's
not necessarily the pump action. I don't think we know exactly what will cause it overall. It's just having the condition and the body reacting in a certain way. There is a certain, and we'll get to that, there is a certain form of heart disease that can develop more in women than in men called stress cardiomyopathy or Takotsubo syndrome, where basically due to the change in the stress hormones in your blood, if you're in a stressful situation, that actually directly affects your heart and the heart muscle and can cause acute weakening. So similar, there are changes in the body that can cause problems.
Wow. And do women have blockages in arteries in different places than men do? And they talked about the, that one place in the LAD that is the
Widowmaker.
Yeah.
So basically, women often have no obstructive disease. So they do have symptoms of heart disease, but they don't necessarily have the true tight blockages that we see more in men, or they can have microvascular disease. I'll get to that in a little bit too. But we do see more and more also with the risk factors, with the overlapping for men and women, we do see similar presentations.
Okay. Thank you.
Okay, any other questions?
Not at this moment.
Okay, very good. So one of the other big problems is obesity. So a lot of us are trying to keep a healthy weight, especially now during this pandemic, where we are all moving less. So ideally, our weight should be in the normal range, which is 18.5 to 24.9. So in order to calculate a body mass index, we'll look at weight and height, and then that's being multiplied by a factor of 703. So as soon as you're at a number of 30, you're being considered obese. And we do have an obesity epidemic in America. So more than 2 in 3 adults in the US are considered overweight or obese. The impact of obesity on the development of coronary artery disease appears to be greater in women than in men. And for example, the Framingham Heart Study, obesity increased the risk of coronary artery disease by 64% in women compared with 46% in men. So again, women are more affected by being obese than men are. And there's a significant increase in coronary artery disease. Physical activity is also seen more in women. So inactivity and sedentary behaviors are higher among women than in men and are a big contributing factor. Hypertension is also, of course, seen in men and women. A lot of people struggle to maintain a good blood pressure range, which is considered to be 120 over 80. That's the ideal range, which decreases the risk of a heart attack. There are multiple factors, as you've probably heard before in other talks, that can influence your blood pressure. So a poor diet with too much salt can really wreak havoc on your system and bring your blood pressure up quite high. Lack of physical activity, too much alcohol, smoking, and stress can bring up the blood pressure. We do see more high blood pressure in women over the age of 60 than in men. And it's often also less well controlled in women than in men. And some of this may also be due that women are not treated as aggressively as men are at times. Another big factor is cholesterol. So the cholesterol is a waxy, whitish yellow fat and a crucial building block actually for our cell membrane. So it's something that we need. We just don't need too much of it. Your liver and intestines make about 80% of the cholesterol you need to stay healthy. Only about 20% comes from the foods you eat. And there's bad cholesterol, the LDL, that we try to really control because it contributes to plaque formation. So once someone has had heart disease, that number we want to keep really low at below 70. And then the good HDL regulates the LDL storage and promotes excretion. So that's actually something we want to be high. Unfortunately, there are no proven medications really to upregulate that. So what you can do is to bring this up is to eat healthy, to exercise, and sometimes unfortunately we'll have to live with a low HDL and just really strongly focus on controlling the LDL. Among women, dyslipidemia or high cholesterol lipid abnormalities have the highest population attributable risk at 47.1% compared with other known risk factors for cardiovascular disease. What we do see in women, maybe statins that we use to control the cholesterol and to bring it down may even have a better effect than in men, and also may even contribute to atheroma regression. So meaning plaque that has formed within the arteries may be reversed to some degree, if not fully, but at least to some degree, we see better results. So what can we do about these traditional risk factors, men and women alike? So primary prevention before something happens. is basically not smoking, maintaining a healthy body weight, consuming a healthy diet, consuming no more than a moderate amount of alcohol, and be active. So at least 30 minutes for 5 days a week. So there was a nurses' health study that showed that women, by doing this, can reduce their risk of coronary events by more than 80%. So that's a pretty high number. So if you can't get in the exercise, which is a big factor, we now know, so this is good news, that actually everything counts. So if you can't make it 30 minutes a day for some reason, try to do as much as you can. Even if you do just little intervals of exercise, that's already been shown to have a positive impact on your body. Any questions at this point?
Laura?
Actually, I was just writing one down to see if I could state it correctly. Back to what you said about the prevention of statins.
Mm-hmm.
Women, yeah, I think you said women on statins, it can actually help more to have women try this ahead because, and I'm sorry, I missed the why.
So it's due to different biological factors. Again, what is really interesting, what came out recently about statins, I think I can mention it here, even though this is not fully related to our talk today, but it may have been a discussion you've had with your cardiologist as well. So a lot of patients are concerned about potential side effects of statins. And there are a lot of symptoms such as muscle aches that occur or fatigue. And there was actually a recent study in Britain that they were able to show that a lot of this is due to the nocebo effect. So it's kind of, you expect the drug to cause you harm, and therefore you experience these symptoms. So they gave people placebo pills, and the group who received the placebo pills compared to the people who received the statin still experienced the same amount of symptoms. So over 90% of the symptoms could be attributed to that effect. I thought that was very interesting to see, especially knowing that this drug has such a positive effect on people who already have coronary artery disease, or in some cases who bear certain risk factors, certain lipid constellations that we want to treat before anything really happens.
So you're not a great proponent of the PCSK9?
So the PCSK9, basically, if you cannot reach your goal of a lipid, of a LDL of less than 70, then you should be on a PCSK9. So there are people who cannot tolerate the statins, even though there is a study there. If you feel you cannot tolerate the drug, then we need to find other ways to treat you. And so then the PCSK9 inhibitor is a great alternative. What we do usually is a stepwise approach. If someone cannot reach their goal of that LDL, where we start you on a statin, we'll get you to the highest dose of the statin that you tolerate. And then when you've reached that dose and we've tried you on the most potent statin potentially, and you're still not at goal, and we really want to see that number below 70, then we may add on a drug called ezetimibe. If that still doesn't work, we'll add the PCSK9 inhibitor. And again, it's always important to kind of see where are you from how well you're tolerating your drug regimen when we bring this PCSK9 inhibitor on board.
Thank you. And ezetimibe is like an in-between step?
Yeah, it's an in-between step that sometimes helps us because the PCSK9 inhibitor, as you may know, is very expensive. So if you, yeah, so if you can reach the goal with a kind of different regimen that may not affect the patient as much, depending on also what the patient can pay for, depending on their plan, what is their overall situation, then I think it's worth pursuing that, even though we see really good results with the PCSK9 inhibitors, and we're prescribing that more and more.
Great, thank you.
Okay, you're welcome. So I'm gonna move on to the non-traditional risk factors. And These are autoimmune disease, as I mentioned before, such as rheumatoid arthritis. It elevates the ischemic risk of heart disease as much as diabetes. And then systemic lupus erythematosus, another autoimmune disease, which portrays a threefold higher risk of ischemic heart disease events. Gestational diabetes, this basically comes along with a fourfold higher risk of having diabetes long term, and it basically has a 59% higher risk of myocardial infarction, a heart attack at some point. And then we briefly already touched on this, high blood pressure in pregnancy. So either gestational hypertension, which mainly just means having high blood pressure in pregnancy, or preeclampsia, which is a certain condition where the blood pressure is high, there's swelling, there's protein in the urine, so it's a little more dangerous combination of symptoms that leads to a threefold higher risk of having ischemic heart disease. So it's very important to try to optimize pregnant patients as well, as far as we can with drugs that are safe in pregnancy. And then depression, we briefly touched on this before, more prevalent in women and doubles the risk of ischemic heart disease. Early menopause also confers a 4.5 times higher risk of ischemic heart disease. That basically brings up the question of menopausal hormone therapy. At this point, we know it's not helpful. It can actually be harmful. There is upcoming research. There are questions. Could we time this differently? Would there be a positive effect if we use it during a different time frame? But at this point in time, we definitely do not recommend for hormone therapy for the protective effect of estrogen. It will cause harm rather than good. So I'm going to move on to the clinical presentation now, and this may be a picture some of you may have seen in the past. This is a picture of an elderly Caucasian male who is clutching his chest. And this was basically a picture that was used in Netter, one of the big medical books. And this is what physicians saw, and when they were in training, what they were trained to see, and what the patient is they should expect with heart disease. But we're at a time now where we're finally realizing with a lot of effort that heart disease has many faces, and it can affect women of all sizes, color, shapes, whatever is out there, we're all affected potentially. And there are some more prominent people such as Rosie O'Donnell, who's had a heart attack, or even Mother Teresa, who's been affected by heart disease. So it doesn't stop anywhere. Unfortunately, we all need to be aware and need to make sure that we do our best to kind of prevent this, or if it's already manifested, coronary artery disease or other heart disease, to provide optimal treatment and optimize all the risk factors. So there are some differences in clinical presentation, as you alluded to in your introduction, but still chest pain remains the most common symptom for men and women. So if someone's having chest pain, that should really be taken seriously. Compared to men, it's fewer women who have chest pain, so 31% compared to 42% of men. Women are generally older when they present, and they have more risk factors at the time because they present at a later point in life and may have developed hypertension after the age of 60. So some of the more unusual symptoms that women may develop is shortness of breath, weakness, just fatigue, cold sweats, dizziness, nausea, and then the arms may feel weak and heavy during a heart attack instead of having the typical chest discomfort. There have been studies that looked at what happens before a heart attack, like a month before. Do people have symptoms? And women have described unusual fatigue, sleep disturbance, shortness of breath, indigestion, anxiety, heart racing, also arms feeling weak or heavy. If you read that column though, I think a lot of people feel like they're going to have a heart attack soon, especially now. We all have a lot of anxiety, so I don't want you to take this to heart too much. This is just to show you there are basically atypical symptoms that women can have, and it's not the elderly male who's clutching his chest necessarily. And we just all have to have that awareness as patients and as physicians. So in women, there's also a greater likelihood of symptoms, in particular chest pain, that can be induced by rest, sleep, and mental stress rather than activity. So we often had this notion to say, oh, this is just, you don't have typical angina, you don't have typical chest discomfort, where when we think about typical angina, it's something that develops while you're being active, you're exerting yourself, and then you stop and it goes away. Women can also experience this during rest, sleep, and then also really triggered by mental stress. So this is something we talked about earlier a little bit before. So what is the pathophysiology behind this? So usually it's flow limiting lesions is the typical thought that this will cause problems. So you develop plaque in an artery over time, and then that plaque limits the flow. As soon as your lesion is roughly 70%, it will cause you to have symptoms. There can be plaque rupture. If someone experiences plaque rupture, that will bring someone in with a so-called acute heart attack with an ST elevation myocardial infarction, because there's no flow in the artery, and that will cause certain changes on the EKG, a study where the electrical activity of the heart is recorded, and that is a true emergency. So when the artery is fully blocked, we rush people to our cath lab and try to open up the artery as quickly as we can. But in women, and this is kind of what you asked, there's a different plaque distribution often, and where there is some plaque, but it's not necessarily flow limiting. So there's another full spectrum. So there's coronary microvascular disease, where basically the tiny coronary artery blood vessels that branch off from the larger arteries that we don't even appreciate when we do certain studies are the problem. This is something that occurs particularly in younger women. It has also happened for a long period of time where these types of patients were seen by a cardiologist, and they were told they're just anxious. And they may have a psychological problem, and it was not noted that there's actually a true issue with the heart, and we've become more and more aware. Specifically, Noelle Berry-Mertz, who is based out of Cedars-Sinai, has done a lot of research also on microvascular disease and cardiovascular disease in women. It is not benign when you have this dysfunction of the smaller vessels, so it has a twofold higher mortality when you have this issue. Other abnormalities we see are vasomotor abnormalities, where the artery is not functioning right, and it can spasm. And so basically it can even lead to a full occlusion, a full blockage of the artery when the spasm occurs. Sometimes it just goes away. Other times it can last for a long period of time, and this patient is also taken emergently to the cath lab, and we find that spasm during the procedure. There have been cases where people have received stents for this, where usually the spasm just resolves by giving medications. It's sometimes hard to distinguish. And then there's another special subgroup also often seen in younger women, where you have spontaneous coronary artery dissection. So that's a sudden separation between the layers of a coronary artery wall. So that is something that's also treated very differently, where we basically do just wait for this to heal unless there's an acute obstruction of flow, meaning there's also no flow going down the artery, where we may place a stent, but usually we just let this here heal and treat this medically. And then I briefly alluded to the stress-induced cardiomyopathy, where there are high circulating levels of stress hormones that are causing heart dysfunction. It's also something we've become more aware of.
Oh, may I ask a question about that? Sorry, I didn't even get a chance to put it in. Is using nitroglycerin a way to cut down on that last one, the stress-induced No.
So the nitroglycerin is basically a drug that will help the heart vessel relax. It'll dilate the heart vessel. So that would be something that would work really well for, and something we use actually for the coronary artery spasm.
But not if you are feeling very tense or anxious, to take that to help your heart is beating quickly. I thought using the nitroglycerin was a very useful.
If you're having chest discomfort, yeah. So it kind of depends on what is the underlying issue. So it won't help for stress cardiomyopathy. So it won't help for that part. So what happens for stress cardiomyopathy is that usually patients experience a stressful event, which can be very different for the individual. So there are people who just get into an argument and they experience such high stress level hormones that it affects the heart. And what happens then is that the pump function of the heart is affected. So the pump function drops, and from the usual normal, it goes to either mildly, moderately, or severely decreased range. And we do see a certain distribution of the heart muscle that's affected. And that's the other name for the stress cardiomyopathy. It's also called Takotsubo's, and that's coined by the way a Japanese octopus trap looks like, because there's basically the base of the heart is still pumping well, and then we see ballooning of the lower part. And it looks kind of like what the Japanese have as octopus traps. And over time with medication, we do see improvement of this weakness of the heart muscle, of the apical ballooning, and we just treat that with medications.
We do have two other questions. Bill asks, how long do these risks persist? For instance, women who have hypertension in pregnancy, does this go away with time?
No.
Ah.
So it is a risk.
That's a clear answer.
It is a risk factor. So what you can do is, so you can try to optimize everything as much as you can. So ideally, for women to go into a pregnancy, they should be in an ideal state of health, right? They should have a good weight. They should have good blood pressure while they're pregnant. They should eat right. As we know, we don't live in a perfect world. So there are people who are going into a pregnancy with pre-existing health conditions, or they develop health conditions such as diabetes. And just because of the changes that the body undergoes during that time, it's very challenging on the body, as a lot of you probably know. So unfortunately, it does, once you've had high blood pressure, it portrays a certain risk. But you can try to be active and really keep a good weight, avoid smoking, all of the things we talked about for primary prevention to really keep you in an optimal state to lower your overall risk.
Another question, this from Tom Love. What about jaw pain? And I'm not sure if that's I don't think that's in pregnancy. It's just. No.
I think he's just referring to symptoms that women may experience when they have a heart attack. So jaw pain is also one of the symptoms potentially. So you can experience chest discomfort. The chest discomfort can radiate into the jaw. It can radiate down your left arm. So that is a symptom that we see in men and women. Some patients will experience throat discomfort. They will feel this like real tightness in their throat. So I think we, in general, as practitioners, we have to have a high level of suspicion. We look at different factors to get like an overall gestalt. Probably if like a 25-year-old with no cardiac risk factors comes in with chest discomfort, we may not think about anything being wrong with the heart as our first differential diagnosis. We may think about other things, but we do have to pay attention because we do see heart disease also more and more in younger people. We've had 28-year-olds who had a family predisposition who were found to have coronary artery disease. So these days, I think we have to have a high suspicion overall. And if someone is coming in with jaw pain and it's not that they just came from the dentist, but they have like a risk factor profile and the EKG may look concerning, and we check certain levels of heart enzyme in the blood, and maybe that even comes back positive, and we will take the appropriate steps to further investigate.
Tom has another question. What about cannabis users?
That's a very hot topic. So I think overall, we do know that cannabis has a negative effect on the heart. There are a lot of articles out there that are claiming it has a positive effect, especially when you smoke it. Then it's also a big issue. So if someone wants to use cannabis, I would recommend at least to have it in an edible form and not to smoke it, but it can predispose to basically also develop heart disease. And there are, if I recall this correctly, I think there's a case report of someone having a lollipop or some edible as well, and they developed a heart attack. So it can trigger arrhythmias such as atrial fibrillation. So overall, I would advise to stay away, but there are a lot of people who also use this to control anxiety, to control pain, and there are ways to maybe use it in a more responsible way, but it is not necessarily benign, and especially if it's being smoked, it conveys a risk.
Okay. Well, and as a comment from earlier, Steve Goulian said that this is great information. He had no idea of the nature of the heart disease risk for women, and he's taking notes for his wife.
Okay, good.
Thank you, thank you, thank you.
That's fantastic. I like hearing that. Well, we're taking one little step at a time until everyone is aware. So yeah, I'm really glad I'm having this opportunity today to talk to you guys. So how did we get to the point to make a diagnosis of coronary artery disease? So now we kind of know there are the risk factors, there's a certain presentation, there can be very atypical presentations, sometimes we need to have a high index of suspicion, but if that is there, we'll usually start off potentially with some blood tests and an electrocardiogram. So the electrocardiogram measures the electrical activity in your heart, and from that we can usually see if it's just a normal EKG, or if there is concern maybe for blockages, or if it looks like someone has had a heart attack in the past and they haven't even noted it. So there's a lot of information to glean just from that piece of paper that we get. Depending on what that EKG looks like, and depending on what the overall symptom presentation is, we may consider performing a stress test, and this can be a treadmill stress test, or it can be a nuclear stress test where we give you medication to stress the heart rather than putting you on a treadmill. If we do that, that also really depends on your overall state, or it also depends on if there are changes on the EKG. We can get an echocardiogram, an ultrasound of the heart. That's basically a study where, and I'm sure a lot of you may have had this before, it's a study where sound waves are used to create a picture of the heart as it beats. So we can see the heart valves, we can see the way the heart muscle is moving. We can basically evaluate the whole structure. And then to look at your coronary arteries to see if there are blockages, there are more ways these days than there used to be. So we can do a coronary CT angiogram where we give you dye through a needle in your vein, and then we'll look at the artery. So that's a non-invasive test, so we don't have to actually go into your body to look at it. Or we will go for cardiac catheterization or so-called angiogram, where we insert a little tube either into your wrist or into your groin. And then through that little tube, we move special catheters up to your heart and inject contrast dye into your arteries and see if there are blockages. And yeah, go ahead.
I'm so excited to have you bring up the coronary CT angiogram. We learned about that through an article years ago, and I've been trying to find a follow-up as a program director, trying to find more about it, because as I understand, as you just explained, a dye goes through a needle and it can identify possible rupture locations by a difference in color of what is there. Since if you just do an angiogram through the tube, it may look fine, even though it's out of round, you can still see it, but the walls include plaque that could rupture into one of those little blister things.
Yeah, so you can get different types of information with an CT angiogram versus a cardiac cath. So what you're referring to is that we can see the plaque buildup in the artery in the wall, and we can potentially identify, because we're getting kind of a luminogram, which seeing the vessel when it's filled with dye on cardiac cath if we don't use any other measures during that procedure. And so it helps us to really look at the artery more closely. What we sometimes do to just gauge risk and help with making decisions, if someone is asymptomatic and they're kind of hesitant taking a statin, they do have certain risk factors, but they are not sure if this is a route they want to go, we sometimes just get a calcium score and see, like, are there calcific changes to the arteries which would support a more aggressive treatment. The cardiac cath also gives you the option to look for plaquing potentially. We can use intravascular ultrasound to evaluate the artery better, for example, and other imaging techniques, but it's not something that's that commonly done, but it's something that is sometimes used or more often used these days than it used to be, where when we look at stents, like how big should the stent be, where should it exactly be, and we can use other tools and not just look at the luminogram in order to optimize the result if needed.
So this thin tube, I'm sorry, I'm looking now at the cardiac catheterization you're talking about. It is what injects the dye into the coronary artery, and then you can tell, I'm sorry.
Yeah, so basically, I'm just gonna go through that procedure real quick with you. So what we do most of the time, so we used to go in from the groin most of the time. Nowadays, we do most of the procedures through the wrist. The bleeding risk is lower. So we usually use, I keep pointing to the left, but we usually use the right arm. So there's an artery called the radial artery there. So we just numb up the area and give you some medication to help you relax. We'll place a little plastic tube in there, and you can think of our catheters that go in like long spaghetti in a way, that have a hole. Maybe that would be then more macaroni than spaghetti, but through which we inject contrast dye. And the catheters have different shapes, and the catheters help us to inject the contrast dye into the artery. So we come up from the arm, we bring our catheter all around into your aorta, and then from the aorta is where the coronary arteries take off. And then we are able, with certain manipulative movements, to get that catheter into the takeoff of the artery, and then we inject contrast dye. So while we're doing all of this, the patient is basically lying on a flat table, and we have a camera moving around, and we're able to take images. And so we have a big monitor, and we're looking at the images. While we're doing all of this, we're monitoring the EKG, the blood pressure, everything. We have a whole big team who keeps an eye on the patient while the physician is performing the procedure with the help of a technician. And then at that point in time, we can mostly make a decision whether, if there's a blockage, if we need to place a stent, or if we maybe need to do more testing in order to determine if a blockage is significant. And then if that is the case, we may place a stent, a little metal mesh tube, in order to keep the artery open. Or if there are blockages in all of the arteries, or if the blockage is in a certain area where it's not favorable to stenting, then we discuss open heart surgery.
Yeah. Oh, thank you, Dr. Kaiser. This is so helpful information. This is what I was hoping to learn more about. I know it's kind of new, actually, isn't it? This is using this particular echocardiogram in the heart instead of other places where it's been used more often.
Yeah, it's really, the intravascular ultrasound, it's just a really, because we work with really small wires and the arteries are really small. It's a really small probe basically that goes in where it's recorded, and but it's something that's been being done more and more in order to identify plaque better and identify like how the stent is actually sitting in the artery.
And would this actually be able to kind of, by using this, could you undo, no longer need to have that pesky stress test that
No,
many of us need?
you know, what is a big difference really here, I think, and what we shouldn't forget is, as much as I love doing procedures and love doing these things, looking at the arteries directly, which is still the gold standard, but it's not without risk. So whenever we go in and look at the arteries, there are risks of bleeding, risks of injury of the surrounding structures. The dye we use can affect your kidneys. It can cause an allergic reaction. Sometimes we can introduce infection, even though it's very rare for severe complications to occur. This procedure carries a risk of stroke. It carries a risk of having a heart attack if we injure your blood vessels in some way, and there's even a small risk of death. So we don't want to do this procedure lightly. And if we have the option of evaluating beforehand, potentially, is it necessary for you to have this type of procedure? Or can we get the information we need in a different way, such with a CT angiogram? Let's say it's actually someone younger. We don't have a high suspicion. They have a good weight. They have a good heart rate. We're expecting to get good results on that CT angiogram. Then I would say that should be the first step, because that's something where, even though we give you dye, we don't enter your body and could potentially harm you. Because unfortunately, as great as medicine is, and as far as we've come, all procedures are associated with possible complications, as are, unfortunately, all medications are not without side effects. We've come a long, long way, but I think we should always keep in mind that it's not without risk if we're doing something potentially.
Okay. Thank you. Thank you for laying out those risks that happen anytime you go into the body, but I still hate the stress test.
I know a lot. Are you referring to the stress test where they give you the medication to stress your heart, or just walking on the treadmill?
Either. One
Okay.
where it goes up to 90 degrees on the treadmill, where suddenly you're supposed to stay on. And what does your heart do when you're about to fall off? Or giving you chemicals that make your heart decide that maybe it'll stop. There's risk to that too.
Yeah, no, I agree. It's not all fun, but it can give us good information.
It's just a snapshot though, right?
Not necessarily. So if we do a real stress test on you, then it'll let us know if there is an area maybe of the heart. If we do a nuclear stress test that's not well perfused, or also if there's scarring of the heart. And then for the stress test where we let you go on a treadmill, we look at the EKG, certain changes can tip us into a certain direction of what needs to be done next. But having said that, if there's someone where we know they have coronary artery disease, we have a very high suspicion that something is not right, the symptoms are very typical, then we may skip the stress test and just move on to the angiogram right away.
Thank you.
So it's really an individualized decision, even though we have guidelines. We have the American College of Cardiology who helps us basically organize our guidelines and keep up with the newest data. But I think overall, we'll have to focus also on the individual patient and kind of factor in where they're coming from.
Thank you. I appreciate your spending extra time on this. I don't mean to keep you from the rest, but that just was so
we're almost there.
special. Thank you.
All right, very good. So we've seen that overall the cardiovascular mortality for men and women has gone down over the years. The mortality, though, for women with acute coronary syndrome is still higher compared to men. So they still exhibit a higher in-hospital and one-year mortality. There's a higher incidence of heart failure and cardiogenic shock, where cardiogenic shock means the heart is not able to pump enough blood to maintain an appropriate blood pressure and to allow blood flow to the organs. In those cases, we use either support devices or certain medications to help with the blood pressure. But again, there's still this discrepancy between men and women here. There may be some reasons for this, unfortunately, lying with women, where they may not identify their initial symptoms as an expression of heart disease. This is also just due to general awareness. So medical advice may not be promptly sought, and practitioners also may not evaluate symptoms that represent myocardial ischemia, so meaning not enough blood flow to the heart muscle as early in women as they may in men. And that may still be due to former teaching, and that teaching is also changing over time. There's also still bias in the treatment, basically that men receive more treatment than women do, such as reperfusion treatment, which will be relieving the blockages with either stents or bypass surgery. Also, if you don't have that available and someone comes in with an acute heart attack, of giving so-called lytics, basically a clot buster, beta blockers, drugs that help optimize the work of your heart. They make your heart work less hard and have a mortality benefit. There are given less to women after heart attacks, and also certain blood pressure medications, aspirin and statin, and other antiplatelet agents, meaning things that like aspirin work on the platelets and thin your blood. What is seen more in women is that they're given more nitrates, but the nitrates, they just relieve symptoms. They don't have an overall benefit. They don't have a mortality benefit for you. So there are still a lot of challenges that we're left with. So there's need for improved recognition of the unique biological risk factors, differences in pathophysiology of the coronary or ischemic heart disease, and just unique challenges of sex and gender specific delivery of care in women. There's still a need for increasing awareness of the unique aspects of women's ischemic heart disease in the public and the medical community. And we also need to work on improving adherence to prevention, diagnostic, and treatment guidelines. So in the future, we hopefully have a combination of how our training is shaped, how the government mandates and policies are, how we portray heart disease and how we use technology and social media, how the research community plays into this, and basically we generate data sets that really include women, or maybe exclusive research to women after we've done exclusive research on men for a long period of time, raising public awareness, increasing medical team awareness, and then have specific women's heart clinics where there are specific cardiologists and physicians who will specialize and care for women. And that will hopefully allow for equitable care for women in the long term.
I think it also on there, you should add having women as cardiologists. I think that's a wonderful value proposition for the whole industry. We need you.
Thank you. There has been a big push, unfortunately, over the years. Specifically, the American College of Cardiology has pursued to recruit more women into training. So that's actually an active process that is being worked on. I personally feel very strongly about having more women in interventional cardiology, where there's just really a small amount of women doing this job, placing stents, treating patients with acute heart attacks. We're still at around 5%, I think. So it's still really male dominated, and hopefully over time that is also going to change.
We have some more questions coming in.
Okay.
Let's see, Tom asks, could you speak to gastric issues in coronaries?
Yeah, so that's something that can be quite confusing. So that's always the differential diagnosis. A lot of times we have people coming in and they said, I just have indigestion. And it's not indigestion, it's actually the heart. It can be very challenging for the patient and the physician to distinguish between those two things. Sometimes only additional testing will help us. Oftentimes the EKG will go a long way. What can be quite confusing is people who develop a spasm of their food pipe, because also nitrates will help relieve that. So that can give you a mixed picture. I think it's very important for patients to pay close attention to their body. If they are experiencing a concerning symptom, I would rather have them seek care once too often than not often enough. And it can be reassuring if everything turns out normal and we can just work on treating possibly true indigestion versus getting to a heart attack on time, or treating the coronary disease in an adequate manner. But there are a lot of things that can cause chest discomfort. And usually when a patient comes in, we try to go through all the different steps and through all the different possibilities, and kind of have to make a decision on, is it very typical pain, or is it atypical? Is it potentially musculoskeletal pain if someone's eliciting the pain when they're moving or when we're pressing on it? Is it more an inflammation of the rib cage potentially? But I think especially GI symptoms can be very, very challenging.
Thank you. We have some other people that would love to ask questions verbally. Are you, you mentioned 50 slides or so.
We're here.
Oh, thank you. Because I know that with such wonderful information, I'm sure there are more questions. And since we've reached the official end, that we can go to the end of talk questions. So I think Linda Bitoff has a question.
Yeah, I wanted to ask it verbally because I don't really even know how to ask it verbally, much less in writing, because it's just so difficult. But just listening to what you were just saying about how difficult it is to diagnose a lot of things. You know, I'm a person who had a heart attack at the gym, self-diagnosed with no warning whatsoever, low, good blood pressure, good heart rate, good cholesterol, good weight, you name it. Everything was fine with a heart attack. And I find myself now, just getting anxious at different times, and it's really hard to know. So like you put up that screen, that said, I had a list of all of these things that indicate a month before that you were going to have a heart attack. And I look at it and I go, well, yeah, all that kind of stuff is happening to me right now.
Yeah, I figured that may not be a good slide.
but also as women, I think we tend to be more cautious and also downplay a lot of our symptoms. I think we've had to, historically, if you got to take care of the kids, you got to take care of the kids, and you just put your own health aside. So I find myself in this position of not knowing when it's bad enough to actually seek help. And I'm just wondering if you may have some guidelines, especially when I had the heart attack, I didn't have any chest pain at all.
Yeah.
The ambulance came. It was just all nausea and cold sweat. That was it.
Right.
No pain.
Right.
So
yeah.
Sort of just looking for guidelines. I guess that's a long-winded way of saying help.
Yeah, so I think to start off, I think it's a very difficult situation you're dealing with, and it's a situation that a lot of people find themselves in, especially if they've been in general healthy and they're surprised by a heart attack. It makes it even a little more difficult in your case as you were not experiencing typical symptoms. So what I would recommend is to try to remember what you were exactly feeling at the time. So that may just be what we could consider your anginal equivalent, meaning you're not experiencing the typical chest pain, but you're experiencing something. So that may be one thing that's helpful. It's going to be important that you're not constantly anxious and scared, because that will also have a negative effect. So you kind of have to try, and I know this is easier said than done, but try to find a Zen spot. And some things that may help you with that are things such as becoming more aware of your body, doing meditation or so. And then also maybe for some of these times where you feel unwell, just seek medical attention and come in and be evaluated. And then if you see over multiple times that you're actually okay, that may be something that could help you. I know right now it's not really a good time to come to the ER, and probably a lot of people or we've actually seen that a lot of people have been avoiding that, but that may be one thing, or really working closely with your cardiologist trying to come up with a plan for you. I unfortunately, I don't know what they exactly found for you, and it's probably not the right setting to discuss this here, but it may be very helpful with the background information of the studies that were actually done, what they actually found, if you had obstructive disease, if it's more microvascular disease, how high was the troponin at the time, how is your pump function, a lot of those things that we can look at and really kind of provide reassurance and try to figure out a plan for you.
Could I just follow up with just one thing real quickly?
Sure.
Is there any, this is sort of the opposite of high blood pressure. What if you have very low blood pressure and also very, very, very low heart rate? So my resting heart rate can go down into the 40s.
Yeah.
Is that a concern, I guess?
No, it just limits us in the medications that we're able to give you. As I pointed out, often for heart disease, we use medications such as the beta blockers that make your heart work less hard, but those are drugs that affect your heart rate. So they will bring down your heart rate. It's probably not a drug that you want to be on. It can also affect your blood pressure. So if you tend to have low blood pressure, we're limited in what kind of medications we may be able to treat you with and help certain symptoms and the underlying disease process.
Can I ask a question?
Sally, yes?
Yeah, and I apologize. I typed a question into chat and I cannot see where to send it. I know I'm not very good at this, so I'm missing something here, but I'll find out about that later. I was just wondering if there are any side effects, especially for women maybe, other than the possible muscle pain from long-term use of statins that you said?
Well, so the two main side effects that we're worried about is your liver could be affected, or you could have muscle pain. But again, this is something that is a low number that patients are affected. It's 2 to 3%. So I think the benefits of being on a statin long-term, whether you're a man or a woman, if you are on this for a good reason, outweigh the potential risks of being on a statin, and greatly, because this is a drug that is proven to prevent future heart attacks or strokes, and that is really something we want to do. This is something that has shown to have a mortality benefit, to keep you around longer and to be around without being handicapped by heart attacks or stroke.
Thank you.
Are there any more questions for our Dr. Kaiser, our speaker? Wow.
Oh, no, this is Steve. No questions, but wow, this has been great. This is fantastic information. I'm glad we have the chance to look at this again. I was thinking of my daughters and my daughters-in-law too, as we're talking. Just great information that I can share with them at some point.
Yes, indeed. I'm thank you, Dr. Kaiser, for being so articulate and able to take our questions and give us a chance to look over this again and see some of those charts a bit closer when we take a look at it later. And for all my friends who couldn't be here at the time, I'm going to say, you get a chance to do it again. We can see it. And I'm so glad you're here in the Bay Area and available for these wonderful talks to people in Mended Hearts who are the ones who are really want to hear about the latest procedures and the new drugs and what's happening and how can we deal with the COVID as well as that tickle at the back of our throat or a heart palpitation or something. So.
And if everybody wants to applaud Dr. Kaiser, I've unmuted everybody. So
thank you very much for spending your Saturday with us as well.
Oh, it was my pleasure. Thank you so much for having me. This was a great opportunity, and I really enjoyed talking to you all.
Thank you. And have a happy holiday. And
happy holiday.
Wait a minute. As president, I want to officially thank you for a fantastic presentation.
You go, girl.
We all learned a lot. You better believe it. However, I have one little tiny question. The part that probably scared me the most is the differentiation on how women were treated versus men. And part of that component you talked about to improve this was public awareness. Is there anything as we as an organization can do to help get more public awareness about women?
You know, I think that's a very good question. There have been a lot of campaigns recently. The American Heart Association has their campaign, Go Red for Women. There's a Wear Red Day. I think it can never be enough because we're, again, still not at the level where we want to be. So I think if you have maybe more talks like this and also raise awareness within your friend circle or your family, I think that's a start.
Thank you. Because I think this is grossly important. It was an eye-opener for me as well. Well, we'd like to thank you for taking the time. Anybody else have anything they want to say?
I just want to add my personal thanks very much, Dr. Kaiser, for joining it.
You're very welcome.
Learned a lot.
Yes.
Excellent.
And I just want to say you have the cutest little dog.
Oh, thanks.
Okay.
I will let her know.
Let her know, please. Thank you.
All right. Thank you so much. Enjoy the holidays, and we'll be in touch.
All right.
Okay.
Thank you.
Bye.
Thank you.
Bye.
Bye.
And happy holidays to everybody.
Yes.
We'll meet again in January.
Yep.
All right. I'm going to end the session for now for everybody.
Bye.
Okay. Thank you.
Bye, everyone.